Hello, everyone, and welcome to Fearlessly Authentic. I'm your host, Jody Harrison Bauer, and I'm so happy to have you join us today. If you are a first time listener, this is the show that will educate you, empower you with that education, entertain you a bit, and inspire you to live your most fearlessly authentic life. Because, in my opinion, if we're not doing that on a daily basis or trying to at least, what the heck are we doing here? So let's do it. And today's show is going to help you do that. Please remember to rate, review, and subscribe. And I wanted to also thank you all for sharing and subscribing because we are now a top 5% globally ranked podcast. And that is all thanks to you. So today's guest is going to educate and empower us with that information about health hormones for women. It is a big topic right now. I've had other guests discuss this with me, and Dr. Marko Lujic is my guest today. He has been fed up with the way medicine is running the world, and he decided to go off on his own and start helping and coaching men and women to be healthier. It all starts from the inside out. Of course, we need to be healthy. We need to be eating a healthy diet, exercising regularly, getting great sleep, staying hydrated. That's the baseline. But what happens when we start feeling different? We start as women having some symptoms, perimenopausal symptoms, and we don't know what to do. Well, for me, I waited 10 years before I started hormone replacement therapy. And thank goodness we moved it slow. And now at 63 years old, I am feeling better than I've ever felt in my entire life. Well, I feel as good as I did in my 30s. I'll have to tell you that. And I'm looking forward to feeling even better than ever. So take out your notebooks, everybody. Take out a pen and pencil. You are going to want to take notes. Here we go, Dr. Marko Lujic. Welcome to the show, Marko. I'm so happy to have you here today on Fearlessly Authentic. Could you introduce yourself to our audience?
Yes, thank you for having me, Jody.
I'm excited.
So my name is Marko Lujic. I'm a MD, MPH. So I got started in the medical field as a general surgeon. I did general surgery residency, got involved in hospital-based medicine, doing standard surgical procedures, gallbladders, hernias, colon surgeries, things like that.
Was that fascinating to you?
It was fascinating technically, but kind of what inspired me to get into what I'm doing now was the lack of preventative care or maintenance care that I saw in the human population in general, and then the misguided treatment sometimes by the medical world. So after doing that for the past, few years, I decided to kind of go down the path of preventative care. And in terms of preventative care, looking at, more internal biologic markers, physiologic barriers to becoming better and how we can adjust those.
What does that mean? Because I hear a lot of physicians say biomarkers, and I think a lot of people don't know what that means.
So a biomarker can be a number of different things, right? So say in the world of carbohydrate or sugar metabolism, your biomarkers might be your insulin levels, your glucose levels, your hemoglobin A1C levels. In fat metabolism or cholesterol metabolism, your biologic markers could be the level of each individual type of fat, cholesterol in general. Then there are hormonal biologic markers, such as your testosterone, estrogen, thyroid, progesterone, cortisol, aldosterone, numerous types. And then there are biologic markers for DNA, and kind of there's a multitude of different biomarkers, and it's anything that gives a label or some measure to where you're at in terms of biologic function. So how is your body functioning chemically?
Okay. So when anybody gets their blood work done, those are biomarkers that the physician's looking at.
Correct.
Okay. All right. So going back to you were in the ER, you were getting frustrated and
Yeah, so I found myself in hospital-based care where, doing general surgery, I'm essentially taking people that have to come see me by default because they've endured some sort of event that they now need something done, an intervention. Most of the time it was an organ removed that was diseased or a hernia fixed because their abdominal wall was disrupted. And I was just seeing people come in with these specific issues that I then would fix. But when they left, they really didn't leave more healthy. They just left with that thing repaired. And I liken it to, I use analogies a lot, but like a car.
Right.
So if a car completely rusted out with all four tires, no treads, bad shocks came in, but the front right tire was the tire that blew out, and they come in and I just patch that tire and send that car back on the road,
Right.
the likelihood of the rest of the car breaking down is pretty high. So in light of that, I kind of kept questioning myself, how can I do better for the people I'm with? And yes, it's very satisfying to take someone who's at a terminal event in their life and get them through that. But that's a one-time stop. That's one person I can help. So then I thought, how can I better that experience for the patients, have them avoid that situation where they needed an intervention, and what can I do to help more people avoid those traumatic experiences?
And I think if we could go back to when you were a student in
Yep.
medical school, um, I don't really think they teach that in medical school. It's not really about preventative, right? And I think that's really changed now.
Yeah, so medical school by default is essentially the study of disease process in the human body with histology, microbiology, pathology, and anatomy. And then they teach you a treatment. But all of the treatments are either interventional with some sort of procedural
Mm-hmm.
intervention, or interventional with pharmacology. So we learn to stop those terminal events. For instance, the treatment for high blood pressure in medical school is a medication. Whereas the real world treatment, if you wanted to get the root cause for a lot of the cases of high blood pressure, mind you, there's always outliers, right? There are people that need medication. That's fine. I believe.
So I have high blood pressure,
Yeah.
but it it was genetic.
Yeah. And there might be times where we can't avoid the pharmacology, and that's what it was meant for. But there are many instances where we don't look at the root cause and we don't educate the patient on the root cause: weight loss, lifestyle, dietary intake, exercise, and kind of the prevention of needing a pharmacologic agent if you don't truly need one.
Okay. So medical school teaches you how to treat diseases.
Correct.
Okay. I've never heard it said so succinctly as that. That makes a lot of sense.
Yes.
So as you were working,
Yeah.
when did the frustration build up pretty fast? How long were you already practicing?
Yeah. So I started practicing in 2016. And by 2020, I started feeling this need to do more. And I also started feeling the need that I was being restrained.
So that came from your own personal feeling. You're like, this is not necessarily fulfilling anymore. I'm really not helping the kind of people I want to help. I could do more. Was it something in your personal life, a family member, a friend?
So, well, two things happened. I went through a personal transition of health. I did the typical, I went through residency, lost a little bit of myself in terms of health because you're working a lot, you're eating poorly, you're not sleeping. So I came to this conclusion on my own for my own well-being to adjust my lifestyle and increase my exercise, increase my attention to detail and nutrition. And then I was seeing a lot of people coming in with diseases that were preventable.
Like what?
For instance, as simple as a hernia, right? So,
What exactly? Can you explain what a hernia is?
yeah, so a hernia is, imagine your abdominal wall, and if you were standing inside your belly, so you're like your liver, and you're looking on the outside. There's a layer of wallpaper, there's a layer of sheetrock, there's insulation, and then there's siding.
Okay.
The wallpaper in the human body is called the peritoneum, the sheetrock is called the fascia, the insulation is called muscle and fat, and the siding is the skin. So if you have a hole in the sheetrock layer of your abdominal wall and the wallpaper layer is popping through, that's a hernia. And it will not fix itself unless you repair it.
Now, because we're going to be talking a lot about hormone health for women, are hernias more prevalent with women or men, or is it not gender specific?
So there's not really a huge gender specificity to it. But what I was seeing, which is actually a good lead in, is obesity. And the obesity kind of pandemic we're in right now, with obesity numbers at record high and increasing, and technically in the United States alone, up to 72% of people are overweight, right? And we've adjusted the category of overweight and obesity type 1, 2, and 3, or morbidly obese. But I started noticing that a lot of these disease processes, such as a hernia, were preventable with something as simple as weight loss, or never having initially gained the amount of weight that would create a hernia disruption.
Idea.
Yeah. Yeah. Weight loss, obesity is a big contributor to a lot of disease processes.
Wow. Okay. I had a slight hernia. It
Belly
was,
button,
yeah, yeah, it was fixed.
very common.
Yeah.
And that may be
Sure.
independent.
I think it was like post babies.
Yep.
And so,
Which is like a very good scaled experiment, right? Because when you have a baby and you get pregnant, you have to gain the weight, and your belly expands abnormally.
yeah,
And what happened to you? You got a hernia.
yeah,
So imagine if you didn't have to have the baby, but you voluntarily or involuntarily, however you want to look at it, gained that amount of weight and you develop a hernia. That's something avoidable for a non-pregnant human.
no idea that that was so associated or linked to being obese.
Yes,
And the only reason, not to get off on the tangent here, which I do often on the show,
it's okay.
is that I one day, like maybe 15, 20 years ago, I leaned over to put on a pair of heels.
Yeah.
Felt like I had a baby moving in my belly.
Yeah.
And I'm like, I know I'm not pregnant.
Yeah, yeah.
But what is this like alien feeling? Like
Yeah.
it felt like a baby kicking. And I ignored it and ignored it until I decided to get a tummy tuck
Yeah.
2, 3 years ago.
Sure.
And he said, you know, you have a slight hernia. And I'm like, oh, that's what that feeling was. So now I don't have it anymore.
Yes, so you had something from the inside of your belly
Yeah.
pushing through
Oh, it was a horrible feeling.
with the wallpaper layer popping through the sheetrock. And
Yeah.
that's a hernia. And that has to be repaired because that will not fix itself.
Right. Because if it doesn't, it could be very damaging.
Yeah, you could get a piece of whatever should be on the inside stuck in that hole. The same way, another analogy, a little kid playing on a stairwell, sticking their head through the railing
Yeah.
over and over, and eventually their head gets stuck. And that could happen to your intestines.
Oof. Okay. Glad I fixed it. Anyway, so we were talking about you were fixing hernias. You were going to your story, why you decided that you wanted to change what you were doing.
Yeah, so I saw a lot of these really expensive, really traumatic, really painful experiences that people went through that could not easily per se, but could definitely be avoided with some better coaching and some better mentoring and some better doctoring in the preventative care world. And beating these diseases or these interventions that needed to be performed in hospitals by avoiding risk factors that would lead to them. So, in kind of that spark of interest in that field of prevention, I started looking into it more. And, in the medical practice, the preventative care world is really defined by internal medicine, which is primary care. And it's of no fault to the doctor, but when you're trained in a pharmacologically based medical system with interventions being the end result, the primary care in general standard protocols there just to watch and wait and then tell you when something's broken. So instead of
Which is what we think of as our doctors. Like we don't think about old world thinking, like when I was growing up in the 60s. Like you didn't see a doctor until something happened to you.
until something broke.
Right. Until something was broken.
Right.
So there has been that shift.
Yeah. And back to the car analogy, you go in for oil changes frequently because if you don't change the oil, you could have a catastrophic injury to the engine. So instead of in the medical world adapting that philosophy, we just wait till the engine fails and then try to fix the engine.
Right.
Whereas we could continuously be changing the oil, changing the transmission fluid, doing regular checkups like a car. We actually, unfortunately, it's sad. I use that analogy a lot, but we really do pay more attention to the maintenance of our car and prevention of car damage than we do of the human body in general.
Very true. And they wait for their body to break down before they see a doctor.
and it's frequent. I mean, it's seen every day, but it kind of feeds the system, right? Because if you're healthy and you're not using the medical system and you're not using pharmacology, you're not using pharmacies, and you're not using hospitals, you're relatively useless to the system financially. And I do believe that preventative health starts with food, exercise, and ends up, benefiting you the more attention you pay to it. But really, that's not guided by physicians anymore. That's kind of guided by holistic practitioners or your exercise mentor in a gym or your coach somewhere like that,
Right.
which I believe as a doctor, a medical doctor, or a practitioner of health, we should be involved in that as well. And that really sparked my interest. And then I started becoming more and more involved in gym activities, exercising. And as I said before, paying attention to my nutrition, I realized like even my biomarkers got significantly better and improved. So over time, it just built interest, and then it was a matter of me pulling the trigger and leaving the hospital system completely to come into this world.
That was a big jump.
Yeah, it was
Were you a little nervous, or were you super sure that this is right for me?
So I mean, I knew it was right for me mentally.
Right.
It was something I knew I wanted to do. The hard part is we're all relatively addicted to a salary.
Mhm.
So practicing medicine in a hospital, you're guaranteed a paycheck at the end of every 2 weeks. The running a business aspect of things you don't really have to worry about. There's someone to do your billing, someone to review your charts. There's backing from a huge system in terms of, legalities and medical legal stuff. So it was a big leap to just cut ties. But, I mean, the only way we make progress is to take risks. So, I knew my heart wanted to follow the desire I had to really become more of a preventative care doctor with what I call aggressive health, right? So not just sit back and wait for my patients to have something bad happen, but really investigate their bodies, their biologic markers, their physiology, and get deep into it with them and find the root cause of what might be causing illness in them acutely, but also then what we can do aggressively to prevent illness from onset down the road. And
Yeah.
the data proves that we're really bad at prevention, right? Chronic diseases are on the rise. So like if you had a financial person running the books of your house and you were constantly losing money, you would never keep that financial person on your roster, right? But for some reason, we're satisfied with the health system continuously allowing more and more people to get chronically ill, more medications. I believe the average 60-year-old right now is on 5 medications at least, which to me is a failure of the system because we are misguiding our patients, I think.
I have so many questions for you. My head is spinning because I'm thinking that I have been strength training since I was 20 years old. So it's been 43 years.
Amazing.
And you're 43 years
I'm
old.
43.
Um,
We look the same age, though.
so, yeah. So I didn't know that what I was doing all those years was depositing longevity into my vessel.
Without a doubt.
I had no idea. And I use a lot of the same similarities, metaphors, analogies that you use, which is if you start investing in your retirement in your 20s,
Yeah.
you don't have to worry about retirement
Right.
when you get to be, say, my age. So the same people, men and women, I train just women, and a few brave men, but mostly women that they come to me and they go, is it too late? That's like saying, is it too late to put away money for my retirement? No, it's never too late,
Right.
but you just have to play catch up.
That's right.
And it's not always easy to play catch up. So I suggest to everybody, and this comes into what you're saying, preventative. You want to prevent working until you're 100 years old.
Yeah.
Because let's start depositing money in our future now, so I can enjoy my retirement and my children and my life, and I'm not working and allowing work to make me sick and die.
Yeah.
Same thing with lifting weights, strength training, moving your body, being proactive about your health, coming to see somebody like you, being aware of what's on the cutting edge of science right now and not waiting until something words. And, you know, I've had clients over the years that came to me and say, can you help me lose weight? Right. So, of course, I can help anybody lose weight. But you and I've talked about this. It comes down to discipline, consistency, and commitment.
Right.
So, with anything, whether it's putting money away for your future or having the muscles on your body and low body fat so you can live a long, healthy life. And the reason my head was also spinning is because I thought when I opened up my studio back in 2009, I, I should have had an MD there with me because that would have been amazing for the doctor
Yeah.
to help all of these women learn even more.
Yeah.
So
I mean, I have two comments on that. So an interesting thing is in patients that are aging and specifically with malignancies or cancer, one of the markers of kind of and a predictive value of when they will die from the illness is when they start losing muscle, right? So when we use descriptors like sarcopenia, meaning muscle loss, or then they get cachectic, meaning they've lost so much muscle that they really have none left, you know, greater than.
which is why we see older people who are skinny and frail.
Right. So that, if you just logically look at that as a scale of death, then you have to look at the opposite to be true as well. So a scale of life would be more muscle mass, right? And that doesn't take science. That's more of just reasoning.
Mm-hmm.
And then the second thing I wanted to comment on was in 2009, when you opened your gym, having an MD in there, I think there was such a disconnect.
I do too.
In the MD world, because there still is,
right.
That it's to this point. So I have a very close friend who now I have my medical office in the gym, right? So I had another doctor tell me, well, so you're just a doctor, you know, peddling meds out of a gym. Now, if you really think about that statement, that's a complete disconnect from health. Every doctor, every primary care should have some direct connection to a nutrition facility or a gym facility.
I agree.
Because if you are not explaining to your patients that exercise and nutrition is part of their health prescription, you have a problem. So in my mind, the new age of medicine is what myself and my partner are trying to build, which is a healthcare facility, not just a building in a city that has an emergency department and cutting people up in an operating room. A healthcare facility, that's a sick care facility. That's when you're sick, you go there.
Right.
But a real healthcare facility, which is going to provide you with health and guidance towards health, should be under one roof, a physician, a dietitian, and an exercise scientist who can all three prescribe healthy lifestyle adjustments with insight inside your body from the MD, and then the external training in terms of mechanical movement from the trainers and gym folks. So, you know, a statement like that really holds true to there just being a lack of knowledge from the medical community, which leads me to say in 2009, I can guarantee you, if you had asked a doctor to be a physician in your gym, not healthcare facility, gym, they would have never said yes. And the second piece of that is, as a physician trained, I've also had physicians come to me and be like, "You're partnering with a gym guy? Like
Hell yeah.
you must have to take a huge percentage of that. I mean, he's not of equal value." Now, whether it's humility or smart, I think our value is equal because true health comes from the basis, as I keep saying, of exercise, nutrition, and good medical science.
I agree. So let's get into at the foundation of feeling healthy and well, you must adhere to a healthy diet.
Absolutely.
And if we have time at the end, we can get into that healthy diet, or you could DM me or Dr. Lujic. And from there, that's the foundation. That's point A.
Yeah.
That's where we're starting with a healthy foundation. From there, we can then be very proactive.
Mm-hmm.
And let's take a woman who is in her mid 30s.
Okay.
Where is she hormonally? We're going to get all into perimenopause, before perimenopause, menopause, postmenopause, hormone health, what we need to do. So take out your notebooks, people, and take some notes here.
So I think the base,
Or we could go to the 20s. I mean,
Well,
where do you think a
so
woman
what-
should
well, what
start
I-
being aware of her
child
hormone level?
childbearing years are a big deal
Right.
with hormone levels, but it's so variable due to the details of giving birth and going through nowadays IVF is very frequent and kind of a lot of other factors. But I think if we use ground zero as menopause, which really is will 50 to 53-ish in women.
Right.
For about 7 years before that, women enter into what's called perimenopause. And there are a lot of new data coming out that people are starting to experience those hormone fluctuations even earlier.
Right. I've heard like as early as like 33.
Yeah, 33, 35.
Yeah.
And there's a lot of talk about it. I think it's going to take a little time to build momentum to really find the data, just because that definition needs to be adjusted. But at that point in time where perimenopause starts to happen, or the onset of a menopausal phase, you have huge changes in hormones. So women throughout their life during ovulation experience levels of testosterone, they experience fluctuating levels of estrogen, fluctuating levels of progesterone.
This starts from when they get their period.
The minute they get their period, right? And estrogen, progesterone dictate when they ovulate. These levels are fluctuating drastically, right? From ovulation cycle to follicular phase and all throughout their cycle. So there's ups and downs. Estrogen being the most prominent hormone in women that people know, but progesterone is just as important, and testosterone as well. And then they get into a phase where their ovaries begin to get tired, right? And I use tired as a word, but
It's so sad.
but they're just not making hormones anymore at the same amount they were to
And
start.
that usually starts at the age of 30, right?
Yeah, 30, 35-ish. There's going to be some fluctuation. Definitely by the time they're 40, definitely probably by 45. And when those things start to happen, you start to have some symptoms. And people may not even recognize these symptoms as being a little bit tired, being a little bit forgetful,
Crabby.
being a little bit crabby, right? And you're blamed for that just because you're in a bad mood, but it's actually a chemical issue.
Well, it's even hard when you think of a woman who I started experiencing symptoms of perimenopause at 38.
Yep.
And I remember my doctor wanted to put me on Prozac,
Yeah.
right?
Yeah.
Prozac. And nobody said to me, oh, let's check your blood, your biomarkers, and
Right.
see where your estrogen and progesterone
Yeah.
and testosterone levels. No, Jody, let's just put you on
Prozac.
Prozac. So the Prozac didn't work because I was also diagnosed with high blood pressure, hypertension back then. So Prozac wasn't good for the hypertension.
Right.
And I think so many women do dismiss these symptoms. And by the way, in your late 30s, early 40s, if you were a mom who got married at like say 28, 30, you're in the middle of raising those kids. And if you've got a partner, they're out working, you could be out working too. And those kids need you.
Yeah.
And life is hard. It's hard. It's stressful. Like it's hard to find time for yourself.
Yeah.
And then let it go, I wonder if this is a hormonal issue with me.
Especially when society in general is telling you that it's not.
Right, you're crazy.
I mean,
like go to sleep.
One example is, before 2002, when the Women's Health Initiative came out, there were a lot of women on hormone replacement therapy and doing really well. And then the whole breast cancer movement, which was great,
right,
but the data got misinterpreted and it was sent out to the population that estrogen and hormone replacement therapy in women causes breast cancer. Now they've rescinded that data and they've sifted through it again and found out that it actually reduces breast cancer. It reduces all-cause mortality, and it's actually very beneficial for almost all organ systems in a woman. But before that, there were a lot of women on hormone therapy. And the minute that study came out, about 10 million women came off hormone therapy, hormone replacement.
We're scared.
And the number of psychiatric meds went through the roof.
What year was that?
The curve, 2002.
Oh,
and the curve is...
They got divorced.
Yeah, well, that might have been
that might have been
the curve actually coincides. And it was a big issue, right? because now they had data to say, no, no, don't use those hormones because they will cause cancer. And cancer is one of those words, if you throw out there, nobody's going to do something that causes cancer, right?
That's why I didn't look into hormone.
That's 100%. And that thought process, that school of thought is still very prevalent out in the world of medicine.
Well, I know because I see women who comment on posts that I put up.
Yeah.
And they're like, that causes cancer.
Right.
So let's debunk the myths.
Yeah.
Let's get into it. Go.
So the myth debunking starts with that Women's Health Initiative. So in 2002, they came out with a study, and they studied hormone replacement in women and cancer association. The hormones they studied and categorized as cancer causing were synthetic precursors to progesterone or estrogen. So what I mean by that is you have to take a medication, your body has to metabolize it, and then after it metabolizes it, breaks it up chemically, your body can then use the byproducts of that reaction as estrogen or progesterone. But there's always another byproduct that might be toxic to the body. So these are synthetics. These are not what are called bioidentical hormones.
So how are they made?
So these are made, so the pharmaceutical industry cannot patent a human hormone, right? So they have to make it into a drug or a medicine that is their own, right? So they attach extra molecules of something to it so that then it's patentable so that they can sell it for a profit. Otherwise, the hormones that are naturally occurring in your body, they can't patent. Now, in that study, there was one arm of the study that was bioidentical estrogen alone. And if you look at the data from that arm of the study, it actually reduced risk of breast cancer by about 35%.
Wow.
And reduced all-cause mortality, not just from breast cancer, but all-cause mortality by up to 41 to 45%.
Wow.
So the data is there. It just was hidden because if you released that data, it would essentially debunk the entire study to start off, which wouldn't go with the agenda of more sonograms, more surgery,
Make more money.
more chemotherapy. Well, that's essentially it.
Unfortunately.
Correct. Procedural medicine makes hospitals money. If you look at a business, whatever your consumers are is what you need to sell to, right? And a hospital's consumer is a sick person, not a healthy person.
Right. So from that study that debunked showed that.
And yeah, now the data is out. They've rescinded the initial, I mean, not publicly, but they've said, oh yeah, we made a little mistake, right? Like the synthetic end of it did have some problems with strokes and blood clots. Yes, right? Because it did, the synthetic end. But the bioidentical end of it had no risk, actually reduced risk and made people healthier.
So when did women start? So what do you suggest for women to start if they're before perimenopause? What should they do if they're in their 30s? Let's say early 30s, 35 and younger.
Yeah.
What can they do to be proactive and then give us the phases afterwards?
Well, so a big push of mine to be very proactive is do not use oral birth control. It completely deranges hormone levels in young women.
So what should women use?
So contraception is an issue to discuss, right? And I don't know the right answer to that.
Okay.
I am firmly on board with hopefully pushing medicine to the point where they find things that men can take as well. Even if it's procedural, I think it's a lot easier, less invasive. I think that's a conversation in its own for an hour or two. And then you want to be proactive with your health by potentially getting yearly panels, right? Which aren't just the executive panels that are the primary care or your standard OB might get, but really dive deep into what's going on in your body.
Can you give us a list, or is it too long to read?
No, the list is pretty standard. So if you are experiencing anything or not, I think you should always have a baseline on your.
So before you start feeling any type of menopausal symptom.
Right.
Okay.
I think you should have a baseline on your testosterone, your estrogen levels throughout your cycle, your progesterone level, your cortisol level, your prolactin level, your thyroid levels. And then I think you should have a really good baseline on your cholesterol and the breakdowns of that, not just your standard HDL and LDL, but things called your apolipoproteins, other factors like your LP little a, which is a whole nother discussion as well. I think you should have some really good insight into your carbohydrate metabolism,
Mm.
your fasting glucose, your fasting insulin, your what's called 1,5
And those would be
anhydroglycinol.
important because if it's off, the insulin levels are off, will your body be inflamed?
Well, something like insulin, inflammation can happen, but I mean, diabetes is the ultimate
Right, okay.
end result of that. But all of these play into each other, right? So, like,
Like
if
one can't be separated from the other. They all have to work well balanced together.
right, like, say you had a 35-year-old woman and you were checking her labs yearly, and at 39 or every 6 months, at 39, all of a sudden you saw that her fasting insulin level started to spike, her hemoglobin A1C started to spike, she started gaining weight, but her FSH and LH, which are stimulating hormones from the brain, weren't really spiking too much. So, like, by definition, she's not perimenopausal or becoming menopausal, but her testosterone starts dropping, her estrogen fluctuations aren't as much, her cortisol spikes.
You might be complaining
Right.
about
So
being
now
tired and gaining weight.
that's right. So now you're getting to a point where you're in that like gray zone. It's a continuum,
Yeah,
right? Like life's not all black and white.
right.
And now you can start intervening a little bit with potential lifestyle adjustments, potential exercise adjustments,
I see a
potential.
lot of women at that age,
Yeah.
37 to like 40, and then after menopause.
I mean, the standard complaint is I don't eat a lot.
Why am I gaining
I don't,
weight?
I'm not eating and I'm gaining all this belly fat, right?
I can tell them what it is.
Well, there's a couple factors.
Right. Obviously, get your hormones checked, but why, for me, not to get off on me, but it's, you know, you're not eating that food.
Right. And that this will get into our exercise nutrition
Yeah.
portion and or the right breakdown of foods, right?
Right.
But a lot of this, I mean, I see it every day here. We have people at the gym that are working hard. I mean, you're talking like hour a day, 5 days a week, intense, and they can't lose the weight. And I get a hormone panel, I get a lab panel, and I can within an instant predict what's going to happen. And within 6 months, we see a huge difference.
Before we go on to what happens after that time period, after you get a baseline, it does take an expert like yourself to be able to read the blood work correctly, right?
Yes.
So what I've said, and I'm just a layperson here,
Yep.
is that you need somebody who is experienced in reading your lab work, because so many physicians that I've heard about will read it and just say you're within the range.
Yeah, this is a
And
topic.
it's not about being, yes, the range, great. I hope you are in the range, but the end result is to get you to be at the optimal
Right.
range, not just in the range, because the range is very wide.
Yeah, the range is based off ages 18 to 90 years old.
Yeah, that's
so
big.
like an 18-year-old might not be the same as a 9-year-old. And there are so it's crazy to me because like humans are so individual, right? Like there is so much difference in a human's body based from one to the next. But we use this algorithmic medicine with ranges. And why do we do it? Because number one, we don't have enough doctors. It's just we don't. And number two, if you calculate an average, right? So if you build 1,000 airplanes and it only costs you $100 to do so, and one plane falls out of the sky every 10 years, but that doesn't really disrupt the general population's ability to fly or willingness to pay, you're probably not going to invest more money in the safety of your planes.
Right.
Because the general population's okay with that amount crashing.
Mhm.
Well, the general population with humans is okay with living to 75.
Yeah.
And how many people do you know die at 78 and they're just like, Jane had a heart attack, but she made it to 78. She lived a good one. Now, who knows? Jane might have made it to 100
Right.
if you'd been paying attention to her biomarkers when she was 30. We don't know. So the medical community has realized that less is more, meaning Less effort put into patient prevention is more money on the back end in terms of intervention.
Right.
And they haven't caused such a problem that the population is going to revolt. Right. So, like, if all of a sudden you started seeing hundreds of thousands of people dying from something, you might have the population be like, no, no, that's not acceptable. But if we just kind of keep going, and not really noticing what people are dying of, we don't revolt. And I mean, look at, like I said at the beginning of this episode, chronic disease is on the rise and nobody's saying a thing. And I get yelled at as a doctor by other doctors for making us think about it. But I said, we're failing.
No.
We are not doing well. Our grade is going down. We are not improving.
And you come from a family of doctors.
Correct.
So you've watched this, your dad, your sisters,
Everybody
is a physician.
All doctors.
So you know how the whole system works.
Yeah.
You see what's going on. So let's go back to the 30-ish something woman.
Yep.
Has no perimenopausal symptoms. She gets her baseline done.
Yep.
So now she's 42.
Yep.
Her periods are spotty. She's
irregular. Yep.
She's tired. She's crabby, and she doesn't feel like eating, but she's gaining weight.
Yeah.
So that would be a good indication, ladies, that you are probably perimenopausal.
Yeah, it's real.
It's real. And I'm going to tell you, from somebody who was prescribed Prozac when I was 38, don't take the drugs. Like, get on hormone replacement therapy, and Dr. Lujic is going to explain what that means before you take any type of antidepressant.
Yeah, and at least maximize what you can control, right? Your food, your exercise, your environment, and then take a real deep look into your biology, right? Because that 43-year-old you're speaking about may start seeing severe drops in testosterone, huge upticks in cortisol, and then big drops over the year or so, right? Maybe a little bit of burnout in the adrenals. Thyroid levels could be changing. Estrogen levels could be changing. Progesterone. And there's ways to coach women through this phase, right? With testosterone therapy. Believe it or not, women love testosterone therapy, and it helps with a lot. Light or no estrogen therapy until menopause, but that's a potential.
Can I just say something about testosterone?
Yes.
So when we say testosterone replace to help build back their hormone and testosterone, that's not just for sex.
No.
That is, people just think, well, my sex life is fine. It's fine. Well, it's not. Just if your testosterone is dropping, that doesn't mean that you still don't desire having sex. How do you feel with your workouts? How do you feel at the end of the day? Maybe you can add more things to that.
Yeah, and it's a huge upper, I would say. That's how I've experienced it subjectively from the women I treat with it. Energy levels, muscle mass goes up, which means caloric burn goes up, which means insulin sensitivity goes up, which means carbohydrate use goes up, which means body fat goes down, which means visceral fat, being the fat inside the abdominal wall around your organs, which is metabolically active and very detrimental to your health. That burn rate goes up and the mass goes down. Bone health. So the consequences of not having it are well beyond just libido and sexual intercourse and vaginal dryness and painful sex and things like that. It's actual medical treatment for the woman.
Yeah, I want women to understand that, because I think that they think if their sex life is okay, then they don't need it.
Yeah, no, it's not just about that. And then that same woman, now that they're 43, as you explained, and now that we're getting into that perimenopausal phase, like I said, there's markers to then track, because once that starts, it's inevitable they're going to enter into menopause. And then instead of letting them experience those symptoms, like you said, anxiety, depression,
hot flash,
right? All of those we can coach through with testosterone, estrogen, and progesterone replacement, all three.
And women, because of that test you talked about earlier, who haven't read recent studies, still believe that they shouldn't have any therapy, and that it's sort of like a rite of life passage.
Yes.
They must struggle. They must be miserable.
Yes. So I
And you
had
don't.
two things happened. I was speaking with an OBGYN and she made a doctor joke to me, which I didn't find funny, but she's like, every menopausal woman is entitled to a little bit of osteoporosis, right? Which is insane. That's a very well-known OBGYN in this area, in women's health, specifically women's health labeled. Then the same OBGYN told me that not every woman is a candidate for hormone replacement therapy. Now, if you get deep into somebody's medical history and they do have barriers to entry, that's fine. But every woman who's menopausal, who opens a door to an office and says, I feel terrible, is a candidate till proven otherwise, right? So in my mind, everyone's a candidate, not the opposite. I don't need to go seek out the ones that are candidates. I would rather every woman investigate the possibility of becoming somebody who is treatable with hormone replacement therapy rather than the opposite, meaning everybody's told not to, and then we pick and choose who can. Because at the end of the day, we have essentially, we have the science available to go against what time has taught us. And what time has taught us is that women go through their period, they become fertile. They give birth, they bear children, and then the minute they stop bearing children, they're essentially sent to pasture.
Yep.
And then when they hit menopause, they die.
Yeah.
And the proof is in the pudding with one major fact. Cardiovascular disease kills more women than men. That's an unknown fact. Everyone thinks of the guy that dies of heart disease, but women die more. And the highest percentage of women that die from that disease are in menopause. So clearly, if you lived your whole life with a full set of hormones available to you and you didn't have heart disease or vascular disease, and we shut that off, now you die, right? So the science available to us now, which to me is amazing and just isn't being exposed, is that you don't have to live out that fate of getting to menopause kind of out in pasture by yourself with no help and just waiting to die, right? Like you have the ability to make yourself feel better and really live a lot longer.
Yeah, that's what I think everybody wants, and everybody who's listening to the show wants, is to live longer. We don't have to repeat history. This isn't our grandmother or our mother's menopause anymore.
No.
We're living longer. They didn't live as long as we did.
And the crazy part is I talk to some women that come in here who are in menopause. They're like, well, why would I want to live longer? I feel like this, right? Well, yeah, but that's a sad part that's our
I didn't
fault.
read that. Yeah.
That's our fault as doctors. Because yes, if your quality of life is terrible,
You don't want
yeah, you don't want to live longer.
Right.
But if you were coached through that phase of menopause and you felt like, say, you do,
Mm-hmm.
right?
Right.
Why would you not want to live longer?
I want to live as long as I
Of
possibly
course.
can.
And if you could live feeling like you were 45 for the rest of your life,
I am 45.
you would want
Yeah.
to do that for everybody out there.
Exactly. So I love that you say you coach women through this hormonal therapy.
Yes.
So tell me, okay, so we hit the menopausal woman.
Yes.
She's coming in, she feels miserable. We get her on. Are there women that should not or cannot be on hormone replacement therapy?
Yeah. So there are some hard no's,
Right.
right? And there are women that if they are currently experiencing, ovarian tumors or uterine cancer, or in the current throes of breast cancer treatment with potential estrogen blockers, or they have a very recent, within the past couple of years, history of breast cancer, you may not want to stimulate that. I will leave a little asterisk by there because if the medical legal world didn't exist, that argument would even still probably be adjusted because there's technically no proof that recurrence rate increases with hormone replacement. It's just if the primary tumor were to recur, it might grow faster.
Okay.
So that's about the only barrier to entry. Aside from that, every woman would feel much better if they were coached through this. And even so much as to say, with bioidentical progesterone therapy, which is a very unknown hormone out there. So estrogen and testosterone are like the well-knowns. Thyroid is like the stepsister that's kind of well known, but like a little bit in the back. And then progesterone is like the unknown cousin that showed up to dinner, and you're like, who the hell are you? But progesterone is very important for women. And
DHEA.
no, well, DHEA is in that process of making all those, but progesterone itself, if given to a woman, bioidentical, is actually protective of uterine cancer, reducing risk to like zero. I'm sure there's outliers, but if you look at the data, it's essentially you take bioidentical progesterone, your risk of uterine cancer goes to zero. Now, barrier to entry to that, if earlier in your life you had a diagnosis of uterine cancer that was progesterone or estrogen positive, now you need to wiggle that data a touch and barrier to entry. But these are very few and far between. But every female, until you weed out the ones that aren't candidates, are a candidate for therapy.
Okay. So
Not the opposite.
you're coaching women. I come into your office and I'm 60 years old. And I say, I think I need to go on hormone replacement therapy. It's been 10 years since I've gotten my period. What do you do with me? Is it too late? Is there a time where it's ever too late?
No, it's never too late. Some of the benefits might not be as profound as if you can get it started within 8 years.
Okay.
I'm going to put out a little PSA.
Because I was nervous. I didn't start until I was 60,
Yeah.
so it's been 3 years.
And I'm going to put out a little PSA for any woman out there who is menopausal and has not been started on hormone therapy. Please, if the doctor prescribes you oral estrogen, a pill, do not take it. Estrogen in a menopausal woman should be given as a cream or an injection because the oral form can potentially cause issues. Now, that's a little side note, but everyone's still a candidate for therapy. Back to your specific point, it is never too late to optimize.
I love that you said it's never too late to optimize. Again, we're talking about optimizing your hormone levels.
Yes, making everything better, refilling your tanks that are empty. And then in a menopausal woman, the things that need to be discussed are if you restart hormones and the levels aren't adjusted correctly or you overshoot, which, as a practicing physician, you got to do it very conservatively, build slowly. You don't go for broke and then try to retract. You could potentially have some aesthetic issues like hair loss, acne, things like that.
Some weight gain.
And those things are coachable as well and adjustable. And then the biggest thing, the most annoying complication for a female is if you're menopausal and you start to have spotting or bleeding. And that's really a matter of your estrogen dose. And some women, you might have to reduce the dose close to zero, just a little bit, or some women can't handle it at all. But an ultrasound of the uterus, look at the uterine wall lining to look at the thickness for polyps or anything like that is easily doable as a screening mechanism or as a reactive mechanism to spotting or fullness. But it's truly still not a total barrier to entry and can be kind of managed with a little bit of chemistry.
I really encourage every woman who's listening, whether you're 30 and you have a mom or somebody you love and care about in their 60s who's been postmenopausal for a while, to have them listen to this episode because it's all about educating all of you and empowering you with that education, as I say at the beginning of the show, so you can make the right decisions for you. Because if we're not being proactive or we're waiting for our car to break down, then we're going to be in the hospital.
Yeah.
I know I'm being a little dramatic here, but that's what we don't want for you. And that's why this is so important for me to have somebody like Dr. Lujic on the show to talk about really, like, I'm a no BS girl. So he's just giving it, he's being straight with everything. And I really appreciate how easy it is for you to make it for all of us to understand. So it's not too late if you are postmenopausal. It just takes a hormone expert. Is there any other way to say it? But
no, there's really no category of that.
Yeah.
Because the modern medicine world has not allowed that to happen yet. You just have to seek someone out like myself or, in your area you look for it, but I'm more than happy to help people with that as well. But the biggest thing is just finding it, right? And unfortunately, it's a man's world, right? And if a man can't get a boner, the world does a backflip.
Right.
But if a woman doesn't want to have sex, has vaginal dryness, and feels like crap and is tired, well, you're in menopause. You got to deal with that, right? And that's all you need to know about the medical world in terms of focus on women's health.
And thank God we're talking about it, because when I was going through it, we didn't have any social media. But now, thanks to all the Gen Xers out there who are shouting from the rooftops about being menopausal, it's brought so much attention, that attention that you and I were talking about.
Yeah.
Like, if nobody's bringing it to attention, like, why aren't more people helping with obesity? Well, they say Ozempic is helping with obesity, but that might be for another episode. I love what you're doing. Thank you so much for being on the show. And
Thanks for having me.
so much. How can our listeners get in touch with you?
The easiest way is to email Becca, BECCA, at rtsct.com. So that's Becca, BECCA, at rtsct.com. And with an email for an inquiry, we can get right back to you. Happy to answer anything.
And they can follow you on Instagram.
And they can follow me on Instagram at Lujic_RTS Health MD. My first name is Marko, Marko. Last name is Lujic, Lujic, and that's at Lujic_RTS Health MD.
Wonderful. Everybody, thank you so much for listening.
Thank you.
And until next week, go live your most fearlessly authentic week. Bye-bye, everyone.
Thank you.